Good afternoon. Welcome to our Facebook Live program on Bispecific Antibody Immunotherapy. I'm your host, Rachel Sachs, Senior Director of Education at the Cancer Support Community. The Cancer Support Community believes that no one can or should face cancer alone. So we work to help people cope with cancer and become more empowered in their treatment. Our team offers a range of services such as patient navigation, financial counseling, genetic counseling, pediatric support, and much more. People have access to free in-person services at one of our 175 locations around the world. We also offer support online and through all of our toll-free helpline numbers. I would like to welcome today's guest to the program, Dr. Ian Flinn. Dr. Flinn is the Director of Lymphoma Research at the Sarah Cannon Research Institute in Nashville, Tennessee. Dr. Flinn also serves as a director for the Sarah Cannon Center for Blood Cancer at Tennessee Oncology and TriStar Centennial Medical Center. Dr. Flinn is here to help us learn more about how bispecific antibody immunotherapy drugs are being used to provide a new option in the fight against some cancers. Thank you for joining us today, Dr. Flinn.
Well, thank you for the invitation. I appreciate it.
Absolutely. I would also like to thank our generous sponsor, Amgen, who made this program possible today. Dr. Flinn, I have some questions for you first, and then we'll open it up to our live audience afterward. Does that sound okay?
Perfect.
Great. Let's get started. Researchers have been trying to use the body's natural defense system to fight cancer for more than 100 years. Recent findings have helped scientists understand how to make drugs that work better with the immune system. People with cancer may hear about these advances and wonder if this type of treatment can help them. Can you tell us a bit more about immunotherapy drugs and just how they help the immune system fight cancer?
Sure. As I think most people realize, our immune system is designed to protect us against a variety of invaders and pathogens, infections, like pneumonia, viruses. But its also its job is to protect us against other things that shouldn't be in our body, other illnesses like cancer. One of the issues that's long been recognized in cancer is that for reasons that vary from one cancer to the next, the cancer evades our immune system. So immunotherapies are designed to try to overcome that issue by allowing the immune system to see the cancer and to augment it, to boost the immune response against it and to get rid of the cancer. And so there's a huge array of different types of immunotherapy, but that's the basic approach.
Okay. So you really led into my next question perfectly. There are several types of immunotherapy treatments that fight cancer cells. Can you tell us what are the different ways these drugs actually work?
Yeah, well, it changes almost daily. I mean, we're finding new ways to use the immune system to fight cancer, but you can basically lump them into sort of three categories. One is a way of boosting our immune system. So part of our immune system that's already there, so it's better able to fight cancer. We can use immunotherapy to basically label or mark cancer cells so that the immune system can now see the cancer and fight and destroy the cancer. And it makes it harder, through that approach, it makes it harder for the cancers to hide from the immune system. And finally, we can, the immunotherapies can help the immune system fight cancers and bring the immune cells right to the cancer and to destroy the cancer cells.
Okay, thank you for laying the groundwork for us. So the use of immunotherapy is on the rise as new immunotherapies are approved to treat people with more types of cancer. And like you said, every day things are changing and new drugs are introduced. About half of current cancer clinical trials include some type of immunotherapy. What types of cancers can immunotherapy drugs treat?
Well, they can treat a broad array of malignancies of cancers. In the blood cancers, we have therapies for leukemia, lymphoma, multiple myeloma. Some of that are currently FDA approved, others that are still in investigation, but very promising. So a huge array of different approaches in blood cancers, but there are also solid tumors that are amenable to immunotherapy. So head and neck cancers, kidney and bladder cancers, lung cancers, melanoma. What I think is interesting is that not one approach works for all the different types of malignancies. So different approaches work in different types of cancers.
Okay. And can you explain to our audience, who are both patients, caregivers, perhaps clinicians out there, how immunotherapy is given, and if you can just lay it out in a really basic way?
Sure. I mean, most immunotherapy, and again, we're going to go through some specifics in a minute, but most immunotherapy is given intravenously right now. Occasionally, it's given as a subcutaneous shot in the same way that, for instance, a diabetic gets a shot, but it's given in that way. But most are given intravenously. Sometimes it's given over a short bolus infusion. There are some therapies we'll talk about in a minute that given as a long continuous infusion by a pump that even a patient can start out in the hospital and go home with it to have that treated. I think one of the goals is to make them easier and easier to give to patients, make it so they're not tied to a hospital, not tied to these long infusions. And I think ultimately it'd be great if we could develop oral therapies, pills that do some of these same functions.
Okay. So immunotherapy isn't one of the options that helps some people with cancer live longer and better, but it's not for everyone and it's not for every type of cancer. Who might benefit from immunotherapy and also who wouldn't benefit from immunotherapy?
Um, well, I mean, I think that it really depends on the specifics of who of the patient, what their prior treatments are, what type of cancer they have. As that there are certain we'll talk about a certain type of lung cancer in a minute that lends itself to treatment with a specific form of immunotherapy called bispecific therapy. But other forms of lung cancer might not really be approachable with immunotherapy today, but hopefully in the future. I think it also depends on so not only what type of cancer someone has, what type of treatment they've had, what the stage of disease is. So sometimes, right now, they're generally being used for patients with later stage cancer, but the hope I think with many forms of cancer therapy is to move it earlier and earlier in the course of the disease, and sometimes it works best for patients who've had little prior therapy. And then I think finally it also depends on what someone's their ability to withstand some of these therapies. Most of these treatments are relatively well tolerated, but there are some therapies that are very aggressive for certain forms of lymphoma called CAR T cells, which require someone to really be pretty fit, and it's hard for the average person to take that. So there's a range, I guess, is probably the best way of saying it.
Okay. And I think something that you would agree with and that all of our clinicians agree with is that certainly feel free. We want our patients and our loved ones out there to feel empowered to do their research, get opinions, but always consult, obviously, with your healthcare team and find out what the research is and what you feel comfortable with and what's out there. But your healthcare team, whether it be your navigator, your hematologist, oncologist, radiation oncologist, that's who you should go to help make the most appropriate decision.
Yeah, absolutely. And this is changing so rapidly. So what was true 6 months ago may have changed completely in 6 months from now. So it's definitely a rapidly changing field.
Absolutely. Okay, so for the rest of our talk, we're going to be focusing, as you indicated, on bispecific antibody immunotherapies. These new drugs harness the power of the immune system to fight cancer cells. In fact, they're so new that it may be difficult for our readers out there and those that are listening to find information about them. So first, it helps us to know a little bit more about some of the cells that make up the immune system and how they actually work. What do we need to know about the immune system to understand bispecific antibody drugs?
Sure. So there are many, as you just mentioned, there's many different components of our immune system, and they work wonderfully together to fight against pathogens such as viruses, infections, and to be harnessed for treatment of cancer. But a bispecific antibody, for the most part, there are two very important parts of it. One is this is engaging something called lymphocytes or T cells. T cells are a particular type of white blood cells that when they get attached to or near a pathogen, or in this case a cancer, they are released to kill that targeted cell or malignancy in this case. There are another very important part of our immune system are antibodies, right? So the example I use here often is that if I give you a flu shot, or now the COVID shot, we develop antibodies that protect us against different organisms, in this case, in influenza. In the laboratory, we can make antibodies that target pretty much anything we want these days. The first antibody that was approved for cancer therapy was in 1997. It was an antibody called rituximab or Rituxan. Well, since then, there's been many, many different antibodies that have been developed. So we're sort of mimicking what happens in our own bodies when, say you get a shot, you develop an antibody against the pathogen. Here, we're making antibodies in the laboratory and infuse them. Well, bispecific antibodies are important that they sort of use both of these systems. Bispecific antibodies target not just one antigen, one protein on the surface of a cancer cell, but they can target two different antigens. One is generally something that's expressed on the cancer cell, and the other is something that's expressed on a T cell. So, for instance, CD3 is an antigen that's expressed on a T cell, and CD20 is a target that's expressed on lymphoma cells. Well, bispecific antibodies that can target the malignancy and the T cell, bring the T cell right up next to the lymphoma cell or other cancer cell, depending on what the targets are, and allow that T cell to engage with the cancer cell, cause what's called an immunological synapse, but ultimately kill that cancer cell. So that's sort of a general approach. There are other variations on this theme, but that's sort of a basic overview of what a bispecific antibody is.
Okay, so I think you really answered my next question about how these antibody drugs differ from other immunotherapy drugs. So it sounds like what you're saying is that most immunotherapy drugs are antibodies that have one receptor that helps target cancer cells, but the bispecific have two.
Exactly, and so in this way, the bispecific antibody is basically harnessing the immune system to fight the cancer. Other types of immunotherapy, such as checkpoint inhibitors, work through a different principle, but also open up the immune system to fight the cancer by targeting something, by awakening the immune system, allowing it to fight the cancer. So that's some of the differences here from bispecific to other forms of immunotherapy.
Okay, thanks for breaking that down for us. So the FDA has approved 2 bispecific antibody drugs to fight cancer. Can you tell us a little bit more about them? So for the first one and most well-known bispecific antibody drug, which is blinatumomab.
Yeah, blinatumomab is was the first antibody, as it said, it's a tremendous proof of principle. It's used for the treatment of acute lymphoblastic leukemia, or ALL. It targets something called CD19, which is a protein on the leukemia cells. And then it also binds to the T cells through CD3, kind of like I was mentioning earlier. And it brings those T cells right up next to the lymphoma cells and allows the T cell to then kill the malignant cell. And so it's binding 2 different things. It's given by a continuous intravenous infusion through a central line or venous line. And it's very highly effective in certain forms of leukemia, most namely acute lymphoblastic leukemia. I think that pretty much summarizes the sort of a quick overview of blinatumomab.
Okay, and the second bispecific antibody drug was just recently approved. What can you tell us about amivantamab?
Yeah, so amivantamab is a slightly different approach where it targets two different targets at the same time. This time, both targets are on the malignant cell, and so it blocks two different receptors. One is EGFR, and the other is MET, and that's important because it blocks these different mutations that are on these different mutations that are part of this lung cancer. They're important for driving the signal that makes the cancer cell grow and want to metastasize. And so by blocking those, amivantamab has an anti-cancer effect. But it also then interacts with immune effector cells in our body and allows our immune system to go after and fight the cancer. So it has more than one mechanism of action here.
And with your experience and these two particular treatments, can you tell us your patients and patients that you've seen, how well they do with these two particular drugs and what reactions, just in case our listeners out there are researching it for themselves?
Yeah, so my practice is really limited to patients who have blood cancer, so I can tell you more about those form of therapies. And we use, and as there are many different, and we'll talk about that, many different bispecific antibodies that are in development. But one thing I think is common to these cells that engage T cells, right, is that there can be infusion reactions. There can be something called cytokine release syndrome. That basically it's like we're asking our immune system to fight the cancer, so we shouldn't really be very surprised when someone gets fevers or low blood pressure, right? I mean, that's sort of a normal side effect of some of these therapies. There's also with Blincyto, there can be blinatumomab, the other name for it. Blincyto, there also can be some neurological side effects, which I think are less clearly understood. They can cause confusion, stupor, even in the rare instance, someone can have coma or seizure-like activity. Thankfully, that drug is given so it has such a short half-life that you can turn it off quickly and it goes away, quite quickly.
Okay.
That's not as with I've not used amivantamab, but it also has some of these infusion-like reactions, not so much of what I was talking about with Blincyto, but it also can have rash that is associated with it, and it probably has to do more with the target than it is being an immunotherapy.
Okay. And what we would say to our listeners out there is that always before getting a medication, typically, within your infusion center or very close by, in your physician's office, you can ask either your hematologist, but there's always usually a pharmacist there that you can talk to, I would assume, before treatment, to understand these drugs, understand what the potential reactions are so that you can anticipate. And also the nurses are there as well. So there's a huge team of support there for our patients so they can understand and plan ahead. Wouldn't you agree, Dr. Flinn?
Yeah, no, I think you've said it really well. You want to interact with your entire healthcare team to best understand these drugs and what's available to you.
Okay, great. So there are at least 55 more bispecific antibody drugs being tested in clinical trials for different types of cancers. What is known about how these drugs work?
Yeah, great question. Most of these bispecific antibodies work fundamentally along the lines for which I've mentioned already. Most are what we call T cell engagers. They have one arm of the antibody attaches to the cancer cell. The other arm of the antibody attaches to a T cell through CD3 or other antigens, and it brings those T cells in juxtaposition to the cancer cell. Now, the reason why we need so many of these different antibodies is that not all cancers express the same targets, right? So what's relevant to a patient with lymphoma is irrelevant to a patient with lung cancer. You need to find a target that's on the lung cancer that's not generally expressed in the rest of the body, because you wouldn't want the antibody targeting to normal cells, at least not very many normal cells. That's the most common mechanism of action. The other approach is the one that that was you mentioned with, or we discussed with the lung cancer drug Rybrevant. It targets different mutations on the surface of the malignant cells, and maybe it keeps them from activating, right? So blocking the signals that make the cancer want to grow, and so that's another very important approach. And yet, there are many other possibilities as well. We've seen bispecific antibodies that are having variations of this, by where they're targeting the cancer cell, but also opening up signaling events. So allowing our white blood cells that are circulating in the blood to once again see the cancer cells. So blocking signals that prevent the white blood cells from seeing them. And so there's many different approaches, as we can almost imagine. As you said, almost half the therapies that are being investigated right now for cancer are some form of immunotherapy. A lot of them play on bispecific antibodies alone, or sometimes in combination with other immune modulating drugs to help them work better.
Okay. So, Dr. Flinn, like most immunotherapies, bispecific antibody drugs show promise in some patients, but unfortunately, they don't work for everyone who tries them. They're also not an option for all types of cancer. So, how can people find out if these drugs might work for them?
Yeah, I mean, I think there's sort of two different approaches. One is those that are already FDA approved, and of course they're well worked out. But there are a host of other ones that are currently being developed for other malignancies. And so I think, first, as you've mentioned, making sure that you've talked with your healthcare team about whether that's appropriate for you or not is probably the first thing that comes to mind. There are, as we said, there's some therapies that are appropriate for one patient and not for the next. For lung cancer, I mean, there's certain mutations that are important. So having an EGFR mutation that has a specific type of that mutation, people can get tested for that. You can ask your doctor or your healthcare team whether you're appropriate, whether you have that mutation, and whether it makes it available to you.
Okay. You really answered my next question. So what I like to note right now is that the cancer support community has a decision support counseling program called Open to Options. It can help our patients and their loved ones prepare for their appointments, during which time they'll be making decisions about their treatment. The program is in English and Spanish, and it's for people with any stage of cancer. To find out more, you should call our cancer support helpline at 888-793-9355. I will repeat that. That's 888-793-9355. So we know, Dr. Flinn, that bispecific antibiotic drugs can cause serious side effects. What are some of the side effects people may have when they take these drugs? You already mentioned them, but is there anything else you want to mention? And if that should be a thought process, when you hear about side effects, patients, it's scary for anybody. But sometimes, like you said, the side effects are short-lived, and the benefit outweighs those side effects. So what else should our patients and caregivers consider when they're talking to their healthcare team about these side effects?
Yeah, I mean, I think it's like any treatment about any cancer therapy. It's about what are the risks versus the benefits of the treatment. So what is the goal of this therapy? What is the chances of this putting my cancer into remission? How long will that remission last? And then think about alternatives to that. So are there good alternatives that are instead of this bispecific antibody, or is this really probably the most exciting and best approach for the cancer? Now, as I did mention, there are certain common side effects with bispecific antibodies. They include cytokine release syndrome that we talked about. Basically, it's your body thinking that this is like one of the worst infections it's had. And thankfully, we know now how to sort of tune down that sometimes and make that less common. There are neurological disorders that can occur. There are also infectious complications that can occur with with bispecific antibodies. And so you'd want to understand what that would look like. Some people get some low white blood cell count, anemia, and other low counts. And so you'd want to, if yours are already low, that might be one reason why your doctor might not think it's a good idea for you. That's something to discuss with them. There are sometimes you can get abnormal liver function tests that can occur. Sometimes this is important, or sometimes it's just an incidental finding that the doctor's monitoring you and seeing that there's some abnormal liver function tests. So these are some of the other things. And then, I think, I'm not sure I mentioned it earlier, but infusion reactions can occur with any kind of antibody, whether it's a bispecific antibody or a monoclonal antibody, just what we call a naked monoclonal antibody. If it's interacting with your immune system, you can get a reaction to the infusion. By and large, those types of reactions are pretty short-lived. The nurses generally monitor you while you're getting it. They either decrease the infusion rate, or they hold the infusion until that goes by. And there are medicines that can be used before these bispecific antibodies are given to try to reduce some of them. Sometimes simple things like Tylenol, Benadryl, even steroids sometimes help decrease this incidence and severity of some of these reactions.
Okay, thank you. So like many treatments, bispecific antibody drugs are costly. So it's a good idea for patients to address these financial concerns before they start their treatment. What tips can you give our audience about the costs, who to go to about their insurance? We know that physicians, particularly this day and age, you have time for your patients. You want to spend much more time than you have in the day because you have a slew of patients in your waiting room. So what do you tell patients when you feel that this type of drug is important for them, and then how they can afford it?
Yeah, those are incredibly important questions, and there are often many, and this is a complex issue, and sometimes you think there should just be a straightforward answer about how to do this, but in my experience, it's never quite as straightforward as you might like it to be. I think, talking, there's usually at the doctor's office or at the hospital where you're getting therapy, usually there are people that can help you understand what your insurance benefits might be, and what your out-of-pocket costs might be. There are often foundations. So a lot of the pharmaceutical companies have funded foundations to help patients with their copays, to help you, get around this very issue. And then, I think it's also important to think about clinical trials. I mean, I'd hate to think that someone went on a clinical just because of, financial need. But clinical trials, oftentimes the drug is given, there's no charge for the drug itself, which is the most expensive part of all cancer therapy. And so that's a resource, but also some of the clinical trials, you're getting tomorrow's therapies today, right? And so the average cancer therapy takes 5 or 7 years to be developed. So through clinical trials, you can sometimes get some very cutting edge treatment today, which might not be available for years. So I don't know if I answered that completely or very adequately. I think it's a tough subject about this, but something I think you just need to be open with your doctor, with the nurses, and they can usually point you in the direction of someone who can help with this issue.
Absolutely. Yeah, you did answer it. And I think, like you suggested, there's oncology social workers, financial navigators, the hospital might have a program. Like you suggested, the drug company might have a program. So we don't want our patients to feel that there's something out there for them and that they don't have the support to afford it. So there are so many avenues. What we would just advise is talk to your healthcare team, because they want to do everything that they can to help get the most appropriate treatment for you. So don't hesitate to ask. We want you to feel empowered and to advocate for yourself and for your loved ones. And we have lots of resources on with Cancer Support Community. Just go to www.cancersupportcommunity.org, where you can get tips on how to ask questions, cost of care information, what to ask your doctors when you're with them in the room. So we just want you to advocate for yourself. So I'm going to ask you a slew of questions that we've gotten both from our audience and that we hear from patients. And let me know your thoughts on them. So if a doctor suggests that we treat their cancer with one of these drugs, would a patient still need surgery, chemotherapy, radiation therapy? What other types of therapies would a patient expect? Obviously, it's very dependent upon their particular case.
Yeah, that's exactly right. I mean, I can, and for the most part, well, for we're talking specifically about the two drugs we just talked about. It's a little bit different. For ALL, you don't generally get surgery or radiation therapy, acute lymphoblastic leukemia, but your doctor might want to use chemotherapy, even a bone marrow transplant after someone's been put into that. You know, with the drug for lung cancer, I think that's probably best discussed individually with your doctor. Unfortunately, it's only for a relatively rare subtype of lung cancer, which is only about 2 to 3% of patients who have non-small cell lung cancer.
Okay. And what we would also say is even if you're talking to somebody that has the same type of cancer as yourself, it might not be appropriate, correct, Dr. Flinn, for that particular patient?
Absolutely. I can't tell you how often I hear that a patient comes in and says, well, I had a friend or someone called me on the
Right.
phone and said, they did this and that. I mean, it's so specific to you based on what you had, some of the mutations that sometimes within the cancer, how you responded to previous therapies, and stage and and not only that, but how fit you are or how fit your friend or other person was. So it's really, really tailored to an individual patient. It's hard to be very general about it.
Can you describe or provide more understanding for us when patients are undergoing this type of treatment? You just said about how fit they are. How important, I think sometimes it's undervalued. Nutrition is both pre, post, during treatment, exercise, whether or not that is appropriate. Also, healing programs in terms of yoga and those types of things, what you recommend to your patients while they're undergoing this type of treatment, and really, for that matter, any type of cancer treatment.
Right. Well, I think fitness is a really important factor that all oncologists think about when they're discussing therapies and trying to come up with a treatment plan for an individual patient. And fitness, I'm not meaning how much weight you can lift, right? I mean,
Right.
I'm not that's not what I mean. I mean basically your endurance, your ability to be up and around the house, even the ability to get light exercise and so forth. I mean, that really factors in. We have all physicians and nurse practitioners, your healthcare team looks at someone and there's sort of objective criteria about whether you're up most of the day, whether you're napping most of the day, those type of things that really, we know that some treatments cannot be delivered to people that unfortunately do not have a very good performance status, it's called. And there's a lot of things you can do to bolster your performance status. A lot of my patients ask me, "Gee, what is the best diet?" And I say, I don't think there is one best diet. I think that whatever your general doctor would tell you is a good diet for your heart is probably a good anti-cancer diet, right? It's more about having a well-balanced diet than it is being on any one fad. And I think that's really important. I can't remember the second part of your question, Rachel.
No, I brought up things about nutrition, health and wellness in terms of exercise, like you touched upon, as well as emotional health, yoga, going to a support group, things of that nature.
Yeah, I think that's all those things play together, right? And we know that's anti-cancer therapy is a multi-pronged approach. There's the therapy that you're getting in the doctor's offices, but there's all these other things that you can do at home that are important for you and your supporters.
Agreed. And I went to a seminar with a physical and occupational therapist really directed for cancer patients. And they said, even I think sometimes we all think about in terms of exercise, like you said, lifting weights or, running or walking a couple of miles a day. And sometimes that's not sustainable for us, even pre-cancer, let alone cancer. So the therapist suggested is even being able to, let's say, walk to the mailbox a couple of times a week. That is exercise. And to really talk to your healthcare team, can't stress that enough. So physical therapists, always there to help support, occupational therapists, of course, if you're having those types of issues, but also at most infusion centers, and I'm sure you work with them quite often, Dr. Flinn, dietitians and nutritionists who are specifically designated to help cancer patients.
Yeah, that's exactly right. So availing yourself of all those resources are definitely important.
Okay, great. So how do you feel that these drugs will change outcomes for people with cancer?
So I think we're just on the tip of our understanding of how to harness the immune system, and and so if we look at the field in general with bispecific antibodies in general, and then immunotherapies, more and more of these are going to be approved every day, and we're working with a number in clinical trials. You've mentioned all the different clinical trials that are going on, but I think they're going to become a normal part of therapy for many, many different patients, for many different types of cancer, for many patients. And so, we just have two that are available today. Wouldn't shock me within the next year we see several other that are FDA approved and part of that. And like what happens with a lot of cancer therapies, these generally start out for patients who have very advanced stage disease for whom other things aren't working so well anymore, and that's where they're first studied. Well, I think the natural history here is that they're going to be moved earlier and earlier in the course of disease. So, from third line to second line to first line therapy for patients. And not all are going to be the same, but I think that's the general theme that we'll see coming over the next few years.
Okay, great. So we're getting some questions, but if anybody has additional questions, please feel free to put them in the chat. So some of our patients who have breast cancer have said, when can they expect that these drugs will be available for more types of cancer? Do you have a sense?
I don't, my practice, I'm sorry about that. I'm really a hematologist oncologist, and my practice is limited to blood cancers. And so I'm less knowledgeable about the timeline for breast cancer, bispecific antibodies, and other forms of immunotherapy.
But what we would say to our audience is that, like you said, Dr. Flinn, things are happening every day, every minute. Research is out there. So just stay, attuned. Feel free to do your research. Always feel free to get a second opinion, but always, once you've gotten a diagnosis, ask your doctor, ask your healthcare team if something would be appropriate for you. Never hesitate to ask a question, for sure. Do you have a sense, Dr. Flinn? One of the things that we hear a lot from our patients is, why do these drugs cost so much money? And do you have a sense? I mean, I guess if we did, we would have won the lottery. When we would expect these prices to become more affordable?
Yeah, the latter one's harder. The first one's a little bit, I guess, easier to, at least for me, to understand. About half of my job is to develop new cancer therapies for patients. So spend half of my time in research, and taking drugs from the first in human all the way through the phase 3 pivotal trials that lead to approval. It takes on average 7 years, I think, is the last figure I saw, and the number of drugs that drop out of this development, 8 to 9 out of 10 drugs that are in development, depending on which phase you look at, are never going to make it all the way there. And so there's a lot of attrition, a lot of expense that goes into these, and that's sort of the short answer why they cost so much. Of course, there are other reasons that, there are all the financial issues that our system has had difficulty struggling with, and sort of incentives and things like that. But I think in the big picture, that's why these drugs cost so much. Now, why they don't get cheaper, faster, and why there isn't almost competition within a class of drugs when they come out is harder for me to understand and much less explain. Sometimes there are several drugs that do relatively the same thing, yet they both cost really expensive. Normal economics, you would think, would drive those costs down when there's competition. And so far, we really haven't seen that.
Right. Yeah. It's hard, and it's hard for patients to hear. But again, there's many resources out there for our patients. So feel free to call Cancer Support Community and talk to your healthcare team. So two more questions. Somebody who has early stage cancer, why are these and other immunotherapy drugs used to treat advanced rather than early cancers typically?
So I think if we're talking about solid tumors to begin with, the mainstay of therapy for patients with early stage is largely surgical, right? So you're giving a targeted therapy. You're going to operate, take the tumor out, maybe also use some adjuvant therapy around it to make sure that there's no micrometastases that escape the surgical incision, or even radiation therapy. So that's really why they're used in the advanced stage treatment. Another very simple explanation is that's how you know whether drug if someone has something that's surgically excised and you can't see the cancer anymore, then it's really hard to know. If they're only microscopic deposits, it's really hard to know whether your therapy is working or not without very long clinical trials with a lot of follow-up. Now, that's not to say that won't come, right? That's what I was talking about earlier, that they're used in the early stage, that these will make its way up the natural history of cancer from third line to second line to first line, from advanced stage to early stage. But that takes many, many years to prove that therapy does anything to help the patient. We'd hate to subject a patient to one of these therapies because even the best therapies we have has some side effects. We'd hate to subject somebody to a therapy if we didn't know it worked. And we don't know it works in those settings, those early stage settings. But I think that data will come given time.
Okay. And lastly, what is your hope? You indicated that a lot of your time is spent doing research. So 2 to 5 to 10 to 20 years from now, what is your hope, Dr. Flinn?
Yeah, I think that in immunotherapies in general, and I think bispecifics specifically, that is advancing very quickly. I mean, most of the research we're doing, if we're looking at the therapies that we're giving in my field, that most of them are immunological in nature of some sort, whether they're taking white blood cells out of a patient, engineering them so that they can recognize the cancer and activating them so that when they do recognize the cancer, they can kill it. Those are called CAR T cells. They are now becoming, they are an improved and normal therapy for patients with lymphoma. They're making their way from third line to second line and presumably first line soon. So I think that general approach of immunotherapies dominating our treatments for patients with both early and late stage cancer, I think that we're going to see acceleration of that. And hopefully with that will come more cures, more longer remissions, changing the natural history of the diseases and having patients live for many, many years. That's my hope for these therapies.
Well, that's exciting. Thank you, Dr. Flinn. We're hoping as well, for sure. So to our audience, the FDA has approved 2 bispecific antibody drugs for use in cancer treatment, but many more, like Dr. Flinn suggested, are being tested. These drugs may not be right for everybody, but the drugs are promising treatment breakthroughs that are helping people with cancer right now. As with all cancer therapies, start by talking with your doctor and making a personal plan for your cancer treatment. I want to let people know ways that the cancer support community can help you and your family when it comes to today's topic. Those who want to learn more can visit the website at www.cancersupportcommunity.org. We also talked about the cost of these drugs. People struggling with the cost of cancer treatment can call the Cancer Support Helpline, the number I gave you earlier. But again, it is 888-793-9355, or visit www.cancersupportcommunity.org/cost for tips on managing and coping with these costs. Dr. Flinn, we can't thank you enough for all of your information today. We wish you and your family and your patients a happy and healthy and safe new year.
Thank you. Thank you for having me.
Absolutely. To our audience, wishing you and everybody in your family a happy, healthy, and safe holiday season and new year. And please give us a call if there's anything we can do to help.